keratitis. There are no financial interests in any of the products which are mentioned in the presentation. And fungal keratitis is important for our part of the world because almost half of our cases are due to fungus. There is a seasonal variation and tends to occur more in the monsoon and the early winter. And I think it is very important to know where geographically you are sitting when you are treating microbial keratitis. For instance, if you look at the fungus, in North and West India, it is Aspergillus, which is the commonest. In South and East India, it is the Fusarium, which is the commonest. There are symptoms such as indolent or foreign body sensation, redness, increasing pain, diminution of vision, and then the classical picture of dry, thick, raised texture with feathery margins, satellite lesions, endothelial plaques, and a fixed hypopyon, which help you to clinically diagnose it. And then sometimes you have demotaceous fungi such as this, where the pigment decreases when you treat it. And Fusarium tends to have a severe course with deep extension and perforation, and East tends to have a collar button configuration. Then for laboratory diagnosis, whenever you do a deep scrape, 10% KOH should be used, which is sensitive 91 to 99% of the cases. And cultures are to be sent on Sabroth's dextrose agar, which are generally positive in 52 to 68% of cases. And it is important in those cases which are culture negative but which appeared clinically to be fungal keratitis. If you do a PCR or confocal microscopy and you pick up the hyphae, then you can start antifungal therapy. We've also described the features of fungal keratitis on anterior segment OCT, and in some of the cases it helps you to pick up the activity as well by the morphology which we see on the anterior segment OCT. 5% netamycin is the mainstay for a treatment for fungal keratitis. So it is given during the daytime and too early at bedtime, and we generally taper at 4 to 7 days interval. And if there's worsening, one can add voriconazole. And therapy in case of fungal keratitis generally lasts for 3 to 4 weeks. And to say whether your antifungal is working or not, titrations of voriconazole was statistically better than those of ketoconazole. And this was the paper that we published. And targeted drug delivery does have a role to play in these cases in the form of intracameral and intracorneal injections because of this limited delivery which occurs in the corneal tissue of the drugs which are currently available. So generally we like to give voriconazole 50 to 100 microgram per 0.1 ml. And there are various studies which have shown that intracameral amphotericin B does work. And this is our study where we compared topical netamycin and intracameral amphotericin B. And this is one of the cases which resolved on amphotericin B. Of course, there are adverse events in the form of pain and anterior chamber inflammations, more with amphotericin B than with voriconazole. And intrastromal injections are indicated in cases of deep mycotic keratitis which are not perforated and not responsive to conventional topical and systemic antifungal therapy for 4 weeks. And there is enough studies to show most of the studies which show that it works. And if you see all these studies, the healing rate is to the tune of 78%. Now, this was a case which was actually the very first case where we gave in intrastromal. And this was planned for a penetrating therapeutic keratoplasty. But when way back in 2006, this resolved on intrastromal voriconazole. And subsequently, we published 3 cases in American Journal of Ophthalmology. And again, we did studies to show whether it works or not. And subsequently, in the series that followed, some of the cases it did seem to work. And these are some of the cases from that study. Sometimes it really just melts away with the intrastromal injections. This is the comparative randomized study that we did to compare topical versus intrastromal voriconazole as an adjunct to netamycin in recalcitrant fungal keratitis. And this cleared one thing at least, that if you add voriconazole to topical netamycin, it tends to have an additive effect. Now, this is just to show how you do it. AC paracentesis is done, followed by the washing of the exudates, and subsequently the intracameral voriconazole is given. And then intrastromal voriconazole can be given in 5 to 6 hemimeridians. Just like you form a macular barrage in case of macular edema with the lasers, likewise, in 5 to 6 hemimeridians, intrastromal voriconazole is given. And the reflex is very much like the.
Are there any questions to Dr. Namrata Sharma?
What should be the? So normally when you add also you tend to give it 2 hourly, the natamycin and voriconazole, and then or hourly. 2 hourly would be the best, especially in the initial period. And when you give it, you tell the patient to dose it like this, that at 8 o'clock you will take natamycin, at 9 o'clock you'll put voriconazole, then at 10 o'clock natamycin, then 11. So in between the two drugs, the gap is 2 hours, but there is any one or the other antifungal which is given hourly. And then subsequently, as the resolution of the ulcer occurs, which could take about, say, 3 to 4 days, then you can subsequently decrease the dose.